Hello, everybody, and good afternoon from London. I'm Rizwan Hamid from London, UK, and I'm chair of the Neurourology Promotion Committee of the ICS. On behalf of the ICS and Neurourology Promotion Committee, it is my pleasure to introduce this first of its kind course in Neurouropelvineology. I will let my colleagues, Professor Pierre Denny from France and Professor Brigitte Church from Switzerland, to let you know the details of the course. All I want to do is to thank everybody, especially both of them, the contributors and the ICS staff, for tirelessly working over the last few years to make this happen. Additionally, special thanks go to the ICS board and the educational committee for their support. We are all very excited to present this first part of the series of this course and looking forward to interacting with all of you. I will now pass on to Professor Pierce Denny for the introduction. Pierce, thank you.
Thank you, Rizwan, and thank you for your kind words. So welcome to the ICS live event. The subject today is Neurouropelviperineology, the basics. And we welcome you to join the discussion and ask the faculty questions via the comments functionality, which you will find next the About section on the page you are watching now. You can leave your questions now, and we will have questions after each talk. If you are not watching this live, you can still leave your questions, and these will be picked up by the faculty. After the live discussion is finished, please join us on the ICS live lounge afterwards. You can chat directly to the speakers and other people watching today in a networking environment. So thank you everyone to be there and to support this event. I would like to introduce my friend and colleague Brigitte Church from Lausanne, and I have to share my screen to show you the first slides. So sorry. Go back. Brigitte, it's you.
So, good morning, good afternoon, everybody. It's a pleasure to have you this afternoon to this first ICS Neurouropelviperineology course. I will discuss with you the aims and of the course, and Pierre will detail the content. So the aim of this course is to improve care and access to care of patients with neurogenic bladder and neurogenic pelvic disorders by the promotion of a multidisciplinary team approach with physical and rehabilitation medicine, physiatrists, neurologists, urologists, and urogynecologists. It's also to promote high-level educational program according to the objective of the ICS Neurourology Promotion Committee, and to give a modern, accessible at home and efficient tool by using program accessible online all over the world on the ICS website platform. So Pierre?
Thank you. So we will try with those different sessions to cover all the topics of neuropelviperineology, from basic fundamentals, for example, terminology, physiology, physiopathology, to medical and surgical treatment. And all those lectures will be done by international experts in the field. So the first one, the one that we have today, is more focusing on physiology, control of lower urinary tract, control of anorectal function, control of genitosexual function, as well as terminology on symptoms and dysfunctions, and from the ICS terminology committee. The second one is about evaluation, how to evaluate patients, and we will have basic urodynamics, non-invasive evaluation, cystometry, pressure flow studies in neurogenic bladder, how to do the appropriate diagnostic of neurogenic detrusor overactivity or neurogenic detrusor underactivity, what is video urodynamics, why, when, and how we can do EMG or vegetative tests for which patients, electrophysiological examination, and last but not least, which is very important, imaging in neurourology. The third session will be on pathologies, and we will try to cover all the different pathologies that we may see in the neurourology field: spinal cord injury, multiple sclerosis, coda equina, disc herniation, brain lesion, diabetes mellitus and other peripheral disease, stroke, and adults, neurogenic lower urinary tract dysfunction, extrapyramidal syndromes, Parkinson and other disease, spinal dystrophies, chronic pelvic pain, and other conditions that a rare physician may face, for example, Inman syndrome in children and other conditions. The fourth will be about treatment. And as you know, there is a lot of guidelines done by the ICS and other societies in the management of those patients. And we will focus on first-line therapies, as well as intermittent catheterization, other voiding patterns, for example, Credé maneuver or triggered voiding, medical treatment of neurogenic detrusor overactivity, medical treatment of bladder outlet obstruction. As you may see, it's a long list. Neuromodulation, surgical treatment of NDO, surgical treatment of neurogenic sphincter deficiency, and surgical treatment of bladder outlet obstruction. And the fifth one will be on sexuality and long-term risk management, to try to cover the different aspects that we have to cover in this activity, not only the lower urinary tract dysfunction, but also sexual dysfunction. And as you will see, we will cover sexuality, erectile, ejaculatory, neurogenic dysfunctions, the general management of those conditions, fertility, sexual dysfunction in women, fertility, pregnancy, and delivery in women with neurological disease, and a very important topic, which is the long-term monitoring in those patients, the renal function, stone risk and management, bladder cancer risk in the population, in the neurogenic population, urinary tract infection, obviously, and aging and neurogenic urinary tract disorders. So that's all for all those contents. And as you may see, we try to cover the different aspects of neuropelviperineology. So I think we will not have a lot of questions about the program. So maybe I would like to introduce the first speaker, or chief, which is Rizwan. Rizwan, it's up to you to do the anatomy and functional anatomy, neuroanatomy of lower urinary tract, storage, and voiding phase. It's up to you from London.
Thank you very much, Piers, for the excellent introduction. And I would encourage everybody to join us for as many of these sessions as possible. I would now start sharing. So thank you very much, Piers and Bridget, for involving me in this fantastic effort. I'm sure that it will become a fantastic resource for the ICS. So my job is to set the scene, laying the basics for neuroanatomy. And I think probably this is my second presentation. The first one is the anatomy one. This was the physiology one. Yes. Oh, no, this is again the anatomy. Sorry, I've got two presentations back to back. So I would like to, oops. I think probably this is not the, just give me 1 second.
No problem.
Neuroanatomy is the one which I want to share with you, which is the first one. This is not, apologies. These are the joys of the internet, that, you know, these things do happen, but give me 1 second and we will get it right.
Maybe you have two windows open at the same time in PowerPoint. Yes. You have to switch from one to the other. You can open the wrong one, but reopen the good one.
Yeah, that's what I'm trying to do. Okay, so now I think I've got the right one open now. Apologies for that. So again, this is the anatomy, functional anatomy and neuroanatomy of the lower unit tract. So thank you for the introduction. And what I've done is to divide this talk into various sections. We need to know what the normal maturation cycle is before we start talking about abnormal. What is the normal neural control of the lower unit tract? What are the neural pathways, both autonomic and sympathetic, parasympathetic, and somatic? What are the storage and voiding phases? And the anatomical considerations. So I'll try to cover this in the next 10 odd minutes. So you can see here that in a normal maturation cycle, the bladder starts to fill up from the left side. Then there's a first sensation to void, a normal desire, and then the bladder empties and the cycle starts all over again. But you can see the highlighted bit that 98% of the cycle is spent in the filling phase. And I think it is very important to acknowledge this, not only in neurogenic conditions, but also in the simple overactive bladder, because we know that the most symptomatic signs for the patients are frequency, urgency. In the neurogenic group, it is the storage phase. If the pressures are high, then they can lead to high pressure in the bladder and damage to the kidneys. So that is where our most of the concentration is treatment-wise. So on that background, what is the neural control of the lower unit tract? The lower unit tract is supplied by 3 sets of nerves, and it is supplied by both the somatic and the parasympathetic both the somatic and the autonomic. The somatic comes from the pudendal nerves, and the autonomic comes from the parasympathetic and the lumbar sympathetics. I think one of the very important things in neurourology is that these nerves contains both the afferent and the efferent fibers. And as we go along today and later on in the series, we'll come to know the importance of this dual function of the same nerve. So here is the innervation of the lower unit tract. And at the bottom, you can see is the pudendal nerve, which is the somatic nerve, comes from the S2 to S4 in the onus nucleus, and we're going to have a look at it in the later on slides. And it supplies not only the external sphincter, but whole of the pelvic floor. And I think it's very important again in neurourology to bear in mind that this supplies not only the external sphincter, but whole of the pelvic floor. So it will be unusual to have isolated bladder problems in a neurogenic patients. Almost always it will be accompanied by the bowel and the sexual dysfunction. A little bit up is the pelvic nerves, and these are the parasympathetic nerves, again coming from the S2 to S4 level. In the later slides, we'll know where they come from. The pelvic nerves come and go to the bladder wall, where they supply mainly the detrusor muscle. And on the top is the hypogastric nerves, which carry the sympathetics from T10 to L2. Generally we call them as lumbar sympathetics, while the inferior mesenteric ganglion and supply mainly the trigone and the internal sphincter area. And we'll try to marry the anatomy with applied anatomy and physiology. So the parasympathetic, like I said, comes from the intermedial lateral horn from S2 to S4, and axons pass through the ventral roots. But the most important thing is what comes at the bottom, where the patients with cardiac minor pelvic injury can be neurogenically decentralized but not completely denervated, because 50% of the postganglionic neurons are in the detrusor valve. And that is why we see patients who have got cardiac type injury, we've got this detrusor overactivity, which is because of this reason that there are postganglionic neurons within the detrusor valve. What happens in the sympathetic pathways? They come from the lumbar cord and provide the excitatory and inhibitory input to the bladder and the urethra. The peripheral sympathetic pathways pass through the inferior mesenteric ganglion, and like I said, they innervate mainly the trigone area and the bladder neck smooth muscles. The somatic pathways come from the pudendal nerve S2 to S4, and not only supply the external sphincter, but whole of the pelvic floor. This is a transection of the spinal cord somewhere between S2 to S3 level. And you can see on the right side that there's onus nucleus is lateral to the nucleus for the levator ani motor, which is in the medial part, and they are in the anterior horn of the spinal cord. A little bit behind that is the intermedial lateral horn of the spinal cord, from where the efferent fibers come for the pelvic parasympathetics. So what happens after the sacral maturation center? The information is relayed by the second order neurons in the spinal thalamic tracts to the pontine maturation center, which is in the middle. And this is the center which is used for the coordination. And I think the most important thing for the pontine maturation center is it is responsible for the reciprocal innervation of the sphincter and the bladder, i.e. the synergy of the bladder sphincter outlet comes from there. And hence in the suprasacral spinal cord injury, which we'll discuss later on, this is disrupted and the patient develops a sphincter dyssynergia. One step up, going to the cortical levels, we know from the hypothalamus with the PAG, we now feel that lots of research is coming out that the bladder control comes from the prefrontal gyrus. On this background, if you put the things together, on the top bit is the reflexes, and on the bottom is the urodynamics. You can see the vesical, abdominal, detrusor pressures, the urine flow, and the sphincter. So as the bladder is empty, from the left side, it starts to fill up. Initially, the impulses will pass afferent through the pelvic parasympathetics to the sacral maturation center, and the sympathetics will do the inhibition of the detrusor muscle and also tightness or contraction of the internal sphincter. On the second set, you can see that as the bladder starts to fill up, the impulses will go up to the pontine maturation center, and then impulses will come down to try to constrict the sphincter, which is known as the guarding reflex. Further moving to the right side, when the bladder is quite full, which is known as procontinence reflex, and here when we are actively trying to inhibit the detrusor muscle, then you can see the sphincter EMG lower down starts to contract. The sphincter is contracted, bladder is relaxed, mainly with the sympathetics. The last figure on the right side, where when it is socially acceptable to pass urine, all is done by the higher center is to withdraw the inhibition. Then the pontine maturation center will take over, will cause the relaxation of the sphincter, contraction of the detrusor muscle. You can see the sphincter down below, sphincter EMG is now flat, some detrusor contraction, reciprocate in the vesical line, good flow, and the bladder empties, and this starts over and over again. So what are the afferent pathways? Like I said, the same nerves which carry the afferent and the efferent, and they go from the bladder or the pelvic parasympathetics to the sacral maturation center. The important thing is that these are carried via small myelinated alpha fibers, and that is different to the unmyelinated C fibers, which are upregulated in the disease state. On the left-hand side of the diagram is the filling state, where again we can see the bladder is filled up. As the bladder is filled up, impulses pass by the pelvic parasympathetics to the sacral maturation center, and by the hypogastric nerves, it contracts the outlet and inhibits the sphincter so that the bladder can fill up. On the right side is the voiding part, where, when it is socially acceptable, the pontine maturation center takes over, leads to the contraction of the detrusor muscle by the pelvic parasympathetics and relaxation of the internal sphincter by the sympathetics, and also relaxation of the external sphincter by the pudendal nerve. So these are the pathways which are the filling, where sympathetics, parasympathetics, and somatics all are involved to lead to the relaxation of the detrusor muscle, contraction of the internal sphincter via the sympathetics, and contraction of the external sphincter via the pudendal nerve. What happens in the emptying phase, when it is socially acceptable, then the pontine maturation center reverses this cycle, which leads to the inhibition of the guarding reflex mediated by the sympathetics. The detrusor is contracted by the pelvic parasympathetics, and the somatic nerves lead to the relaxation of the external sphincter, leading to the voiding phase. In summary, of the anatomy, the onus nucleus homes the anterior motor neurons of the pelvic pudendal nerve, which is responsible for the somatic pathways. Of the sacral maturation center, the pelvic parasympathetics are in the intermediolateral horn of the S2, S3, S4. They talk to each other by the pontine maturation center. The spinal cord ends at the L1 level, and below that we know is the quadrate equina. What is the differentiation between complete and incomplete injury generally is that if there's no voluntary anal contraction, there's no sensation at the S4, S5 level, then the injury is complete. Otherwise, it is incomplete. And last but not the least is in the typical spinal cord injury patient, above the lesion, the sensations are normal. At the lesion, they'll be flaccid, but below that, it's an autonomous distal cord. Thank you very much. And I welcome the questions.
Thank you. I'm not sure we have questions from the audience. I just have one. And thank you for summarizing all the physiology and the anatomy of the lower urinary tract. Just a few words about the role of the urothelium, because you didn't have enough time to elaborate on it. Could you please say a few words about it?
I think, Piers, that might be covered in the physiology. The urothelium, now we feel, is a unit in itself, and it is mainly related to the physiology with the neurotransmitters, and we feel that our friends have got a lot of role to play as the bladder fills up. It's the neurotransmitters, which might be ATP, nitrous oxide, and those things are very heavily involved. And we feel that those will be the targets of the next generation of medications. And there's some evidence that actually even botulinum toxin also works at that level.
Thank you, Rizwan. Do we have another comment from the audience? I'm not sure. From the other speakers for Rizwan? In case not, maybe we can do the next lecture by Rizwan. Thank you, Rizwan.
Thank you very much. So this is my second talk, which is on the physiology and pathophysiology of the lower urinary tract from a neurological standpoint. So I will briefly talk a bit about the physiology of the smooth muscle. and then going on to discuss what is the pathophysiology of neuropathic or neurogenic bladder dysfunction, and then try to summarize and see how it affects the functioning of the lower urinary tract as a motor, as a unit. So here's the neurotransmitters and neuropeptides that Pierre was talking about. So generally, for the autonomic nervous system, there are two parts. One is the parasympathetic, for which acetylcholine is the main neurotransmitter. For the sympathetics, it is noradrenaline or norepinephrine, which is mainly for the sympathetic nervous system. But it's the last one which Piers was talking about, which nowadays we are very interested in the urothelium, which is the ATPs, prostaglandins, nitrous oxide, and 5-HT, and we feel that these have got increasingly more role to play in the control of the urothelium and the physiology of the lower urinary tract, and these are now the targets for the next generation of medications. So coming to the detrusor function and the pelvic parasympathetics, we know that there are at least 5 subtype of receptors from M1 to M5. The most predominant one are the M2, but this is the M3 receptors which mediate the cholinergic contractions. We know that in the parasympathetics, the acetylcholine is the principal neurotransmitter, and this contractile response is abolished by atrophy. As a unit for the smooth muscle, in the M3 receptors, the acetylcholine will lead to the hydrolysis of the phospholipase C. And then you can see on the left side that the acetylcholine will work on the M3 receptors, which will lead to the hydrolysis of the phospholipase C, which PLC. This is going to have the release of the inositol triphosphate, which goes into the sarcoplasmic reticulum, leads to the expulsion of the or release of the calcium, which mixes with the calmodulin to find a calcium calmodulin complex. It leads to the contraction of the detrusor muscle. This is true not only for detrusor, for all smooth muscle. But I just want to bring your attention to this thing, which is the P2 receptors are also there, and we'll come back to that in a second. But this is how the detrusor smooth muscle contracts. What about the sympathetics? And like I said, norepinephrine is the principal sympathetic neurotransmitter for the adrenergic receptors. And it's got 2. If it is acting on the alpha receptors, then it leads to the contraction of the bladder, neck, and smooth muscle, as we know. And what works on this is the alpha blockers, as we know, is going to relax that, which is promoting continence. What about if norepinephrine when it affects on the beta adrenergic receptors? That leads to the detrusor relaxation, where the new drug, not so new now, marabegron or betmiga works. So for the adrenergic side, norepinephrine, depending upon the alpha receptors or the beta receptors where it's working, will lead to the contraction of the bladder neck for alpha and relaxation of the detrusor muscle with beta-3 mediated relaxation. What about the purinergic or P2X receptors, which I mentioned there? Generally, it is thought that during the normal or in the not disease state, they are not that active, but they are upregulated in disease state like obstructed bladder, some evidence in painful bladder syndrome and neurogenic conditions. They are upregulated, and it is felt that it is because of the upregulation of these purinergic or P2X receptors that the antimuscarinics or anticholinergics are not that effective. So on that background, what is the pathophysiology? And this is a fantastic summary slide from ICI, which summarizes the whole of almost all neurogenic conditions we can see. On the left side, you can see this is the suprapontine condition. Then is the suprasacral, which is between the pontine maturation center and sacral maturation center. And this is below the sacral maturation center. So there are three levels where the dysfunction can happen. And there are three types of conditions. One are congenital, which like cerebral palsy will be in the suprapontine. Spinal dysraphism or spina bifida can be suprasacral or sacral. And then this is for the congenital. For the acquired, they are stable, like head injury or spinal cord injury or quad equina, or acquired progressive like multiple sclerosis, Parkinson's, or transverse myelitis. So once we put a disease in one of these 9 boxes, generally we can see what the course would be. And I really like this slide. It's very old slide, and that's why we have put this in bold that unfortunately, it does not follow the new ICS terminology. But the reason I've put that in is this detrusor hyperreflexia, as you know, we no longer use this term. We use the term neurogenic detrusor overactivity. But the reason I've left this slide is that it is very good for understanding. You can see this is the suprapontine or higher centers where these diseases, cerebrovascular accident or Parkinson's, can have, where there is overactivity but no dyssynergia because it is above the level of pontine maturation center. Then between pontine maturation center and the sacral maturation center, which will be a classical suprasacral injury, in spinal cord injury, multiple sclerosis, or transverse myelitis, then everything is overactive. But like I said at the start, it is not only the bladder which is overactive, but the bowels are also overactive. Then, like always to confuse us, there will always be a mixed lesion where the injury is at the level of sacral maturation center, but it can also happen in spina bifida, which is a mixed pattern of both the supra and the infra level picture. And then below the level of sacral maturation center or quad equina, like disc lesion, then everything is areflexive. Not only the bladder, but also the bowels. They go kind of a hand in glove. So on that background, what is the afferent and the efferent pathways? And on the sensory side, it's the myelinated A delta fibers which take the information from the bladder to the spinal cord. And we feel that in the disease state, the C fibers are upregulated, which are unmyelinated. On the efferent side, for the motor pathways, sympathetic, parasympathetic, and the somatic all have got a role to play. For the sympathetic side, it is the relaxation of the detrusor muscle and the internal sphincter, while the parasympathetic, it is the contraction of the detrusor muscle by the pelvic parasympathetics. And the somatic side, it is both things. During the filling phase, it is the contraction of the external sphincter, whilst this is reversed by the pontine maturation center in a reciprocal fashion, where it leads to relaxation of the external sphincter and contraction of the detrusor muscle. On the voiding side, all these pathways are reversed in the once the pontine maturation center takes over, when there is no inhibition from the higher centers, then it leads to the contraction of the detrusor muscle by the pelvic parasympathetics and relaxation by the somatic activity of the urethra in the pelvic floor, which leads to complete bladder emptying. And now both these afferent and efferent pathways are now the target for the next generation of pharmacological therapy. This cartoon diagram is the next 2 or 3 slides very eloquently describe the lesions. So if there's a lesion here, the pontine maturation center takes over, then there is a synergistic contraction of the detrusor muscle. So the patient will have frequency urgency, but it will be a coordinated void. In a way, the analogy is in babies where these pathways are not fully developed, but they're still empty completely. Next, if there is a suprasacral injury, which be spinal cord, transverse myelitis, or in a multiple sclerosis patient, then there's coordinated void is lost. So this became an automatic cord. So that not only there will be an overactivity, but sphincter dyssynergia, where there will be poor emptying, high pressure bladder. The pressure can be transmitted to the upper tracts, leading to renal failure if this is not controlled. Last is if the injury is at the level of the sacral maturation center or below, then the information will not pass from the detrusor to the sacral maturation center. So everything will be areflexic, like in spina bifida, disc lesions, pelvic surgery, or peripheral neuropathies. So there'll be a flaccid paralysis, detrusor areflexia. But like I said initially in the neuroanatomy, that 50% of the cell bodies, like shown here, are on the detrusor muscle. So there might be some overactivity, which is of low potential. But these patients can have frequency urgency, and on neurodynamics might have detrusor overactivity. I put these medical diseases with inverted commas, diseases like multiple sclerosis or cerebrovascular accident. And the most common one of these is the MS, which is a chronic inflammatory demyelinating condition. There are 4 types, but from a urological standpoint, about 3/4 of the patient will have a mixed lower urinary tract symptoms, mostly storage symptoms with frequency urgency, and 2/3 will demonstrate that on neurodynamics with neurogenic detrusor overactivity, but 1/4 can have underactivity also. So the majority will have neurogenic detrusor overactivity. What about the congenital disorders like spina bifida? It's a failure of the neural tube to close. It is still not that uncommon, although the incidence has gone down a lot. But what I want to share with you is that this is quite often a mixed symptom, and we see patients with overactivity, loss of compliance, but also stress incontinence. So they can have a high pressure neurogenic bladder affecting the upper tracts, but also stress incontinence. And the extreme example, we end up doing a cystoplasty with insertion of an artificial sphincter. But nowadays, with medication and Botox, they can be managed. So, in summary, again, the onus nucleus is for somatic part with the anterior horn cells providing the innervation not only to the external sphincter, but whole of the pelvic floor. For the autonomic nervous system, parasympathetics comes from the intermediolateral horn at the S2, S3, S4 level for control of the detrusor muscle, but the sympathetics comes from T10 to L2, and which is for inhibition of the detrusor at the level of the trigone and also contraction of the external sphincter. And they talk to each other via pontine maturation center. Acetylcholine is the principal neurotransmitter on the parasympathetic side. M3 are the principal receptors, and the calcium calmodulin complex will lead to the contraction of the smooth muscle. Thank you very much.
Thank you, Rizwan. We do have a question from the audience. Is it possible that any drugs can lead to dyssynergia?
I think this question will be more for you than for me, but I do not think so. I know of any drug which can cause dyssynergia as a classical, where there's a disruption of the neuronal pathways below the pontine maturation center, which will lead to contraction of the detrusor muscle at the same time when the external sphincter contracts. But I'll welcome your thoughts on this, Peter.
Maybe, but it was not really clearly proven that alpha stimulants like midodrine, because there is a dyssynergia with the striated sphincter, but there is also the dyssynergia with the bladder neck in certain level of lesion if it's above the sympathetic centers. Maybe the midodrine may induce some kind of dysuria, but in my clinical practice, when we use it, for example, to induce ejaculation in spinal cord injured patients, there is no clear or clinically significant modification of the coordination, the real coordination during maturation with those centers. So as far as I know, there is no real drugs to induce dyssynergia. Any comments from the other speakers about the wonderful lecture from Rizwan, who make complex things and explain it in a very simple and clear way? Thank you, Rizwan. Because having the figure of all the neurological control of lower and high tract is always a challenge in 10 minutes. So thank you, Rizwan. So I will share the screen to discuss with you about the anorectal function. So I think it's okay, you see my screen. So the control of the anorectal tract, physiology and pathophysiology. So anorectal dysfunction of continence and defecation is a very common situation in neurological disorders, but because symptoms often overlaps and are poor predictors of pathophysiology, an appropriate treatment is based on good understanding on physiology, anatomy, and physiopathology based on clinical and paraclinical evaluation. And you will see that there is some overlaps with the lower urinary tract, as Rizwan described before. So in terms of anatomy, anorectal control of continence and defecations depends on anatomy integrity. So anorectal continence is a complex physiological process to control both solid, liquid, and gas. And clearly, it's a major challenge. And defecation is a voluntary emptying of the rectum. Those two phases involve both neurological control and muscle of the pelvis. And this is probably one of the differences with the lower urinary tract, that the several components of the levator ani, meaning the pubococcygos, the iliococcygos, and the puborectalis, support the pelvic organs, but also maintain anorectal angulation and create a mechanical barrier for the flow of stools and the maintenance of continence mechanism. The superficial layers of the pelvic floor include the internal anal sphincter and the external anal sphincter and connective tissue. These superficial layers are largely responsible for controlling the evacuation of stools from the rectal vault. During normal defecation, the voluntary efforts of bearing down increase the abdominal pressure together with the contraction of the rectum and the perineal muscles. So simultaneously, the sphincter and the puborectalis relax to open the anorectal angle. For example, in Parkinson's disease, this is one of the major causes of the difficulty to evacuate, the lack of relaxation of the puborectalis muscle. So the pelvic floor receives innervation from the pudendal nerves and the parasympathetic and the sympathetic nerves as well. So what are the actors? In terms of functional anatomy, the mobility of the colon is in charge of the progression of the stools to the reservoir. This mobility increases after meals and physical activity 3 to 10 times a day, and high pressure contraction from the colon push the stools to the rectum. The rectum plays a role both during continence at the reservoir with a capacity and a compliance exactly like the bladder, and during this time, in terms of anatomy, the angulation between the sigmoid and the Houston valves acts as an anatomical barrier. During defecation, the rectum contracts, and distally, the anus is a muscular tube from 2 to 5 centimeters with, as into the urethra, with internal and external sphincter. So the actors during for the functional anatomy is also hemorrhoids, and as you may see here, they act as a cushion during the increase of the abdominal pressure. The anus has an angulation of about 80 degrees with the rectum and has a tonic activity without any voluntary control. The only voluntary control is on the external sphincter, as it is for lower urinary tract, with multiple layers of circular striated muscle, and is in close anatomical relation to the levator ani. You know the levatoroni with the three different components, the pubococcygeus and the ilococcygeus, which apply lateral pressure to reduce the levator hiatus, and the puborectalis act as a strong actor during continence and must relax during defecation. So the peripheral innervations, it's always three sets of nerves that participate to the anorectal function. The somatic innervation comes from the pudendal nerve to the external sphincter, the perianal cutaneous and anal afferences. The levatoroni is not under the control of the pudendal nerve, but receive direct somatic innervation from S2 to S4 spinal nerves. And as for lower nail tract, sympathetic innervation comes from the spinal T12L1 sympathetic centers, and parasympathetic innervation finally from S2 to S4. But there is a major difference in that autonomic nerves play a role as a modulator of the enteric innervation, which is more predominant in terms of control of those functions than in the bladder. So in terms of sensibility, it's a very important part of the control of continence and defecation. The axons that reacts to rectal distension and contraction receptors goes to sacral segments, but anal sensation is the high and rich plexus of receptors that permit to discriminate between solid, liquid, and gas, and they are sensible to touch, to heat, to friction, to pressure. The innervation of the anus goes to the pudendal nerve predominantly by the inferior rectal branch. What are the reflexes that can be evaluated during a way to evaluate the anorectal function, which is the anorectal manometry? There is several reflexes that can be evaluated, such as, for example, the rectoanal inhibitory reflex. During this reflex, the dilatation of the rectum induces a fall in the upper anal resting pressure that permit the discrimination of the rectal content by the afferents at that level. Another reflex that we can evaluate during manometry is the cough reflex. In case of increase of abdominal pressure, there is a reflex that increases the anal pressure in response. And finally, another reflex that we can evaluate is the rectoanal contractile response. This is a response in the external sphincter which contracts during rectal distension to improve the quality of continence during the distension of the rectum. So there is several players which are very important in the regulation of continence. And this is a long list, but this list needs to be evaluated when you see your patients. You have to have a normal transit, you have to have formed stools, you have to have a good anal closer pressure at rest, a good rectal capacity up to 300 milliliters, and also a good sensibility. But also the functional reflex that we described previously are very, very important to regulate the sensation as well as having an adequate cognitive function and appropriate mobility to permit to reach to the toilet in appropriate time, exactly as for the lower nail tract. What is the physiology of defecation? There is a request that there is stools in the rectum and a rectal distension. The abdominal wall, the rectum, and the diaphragm during the voluntary defecation contract to increase the abdominal and the rectal pressure. And in the same time, the anal sphincters relax, as well as the puborectalis to decrease the angle between the rectum and the anus. The synergy between relaxation and puborectalis and the sphincter is a key to permit a complete evacuation of the stools stored in the rectum. If there is no complete evacuation of the stools, you may have a lot of stools within the colon, and you may have, like in the bladder, a kind of overflow incontinence. So this slide illustrates the mechanism that can play a role independently or associated with the pathophysiology of constipation. You can have, for example, usually one or more often associated slow colonic transit, art faces, discoordination of the pelvic floor and abdominal and rectoanal muscles, rectal hyposensibility, and this is a very frequent situation that can reverse with appropriate treatment, and a poor relaxation of the sphincter pressure during defecation. So in conclusion, and you have, oh, sorry, I made a mistake about, I have to go back to the last slide in the anorectal. You have some reference which are very interesting because they cover all the physiology and the pathophysiology of the rectum, both in terms of continence and defecation. And as you understood, there is a major parallelism in terms of physiology and pathophysiology between lower urinary tract that Rizwan explained before, and the anorectal dysfunctions. Symptoms alone are usually poor predictors of mechanism, and evaluation try to discriminate what comes from the rectum and from the sphincter, the coordination between those two players. And there is also a major difference, which is the role and the major role of the puborectalis muscle. So thank you for your attention. I will stop to share my slides. If there is any question from my colleagues? No?
Sorry, can I just ask something?
Yes.
What would be your advice to how to investigate the bowels with the bladder together as a baseline? So, for the bladder, generally we say for the neurogenic bladder that do the urodynamics as almost the first investigation. What will be analogous for the bowels?
As for lower urinary tract dysfunction, I think that the proper stool diary is interesting. This is, I think, one of the first steps. The second one is to evaluate which type of stool they have, and there is this wonderful, beautiful picture where the patient has the type of stool they have. Clinical examination is also very important. In fact, because it's not exactly the same challenge than we have with the bladder, because there is usually less risk of complications as we have within the bladder. We use, based on proper clinical examination, as well as different scales that we may use. We can try different types of treatment on what's going on. And in case of failure, or for example, for first line treatment, sometimes we use manometry. And especially it's interesting in case of mixed incontinence, for example, for patients who do have neurological disorders, as well as pregnancy and injury of the pelvic floor, or for example, patients that have neurogenic disease as well as had a cancer in the region, all those complex cases that mixed surgical injury, neurological injury. In that case, we use manometry, but we don't use manometry as we use it in the lower urinary tract because we don't have to evaluate the risk. So it's only a question of treatment, first line, second line, third line, fourth line treatment. So it's more how we manage the initial evaluation and how we manage the results of the different lines of treatment.
Thank you.
Pierre, I have a question.
Yes.
In cauda equina patient, the patients, they claim not so much on urinary incontinence, only if they have some effort or see they are coughing. But in cauda equina patients, the main complaint is stool incontinence. Do you think it is because there is no equivalent of the bladder neck in the rectum or the anus?
In fact, there is, but the regulation is not is completely different because the anterior plexus play a more important role than the external innervation. This is one point. And the second point is that in those specific patients, the cauda equina patients, I'm not sure that they have the patients have the same concern for their bowel and the same attention for their bowel than they have for their bladder. Usually they use intermittent catheterization, but it's possible to have a good continence in those patients if they have very solid stools. The main question is how they evacuate, and it's sometimes very difficult in that case to have a good evacuation. So it's always a question in the anorectal function of evacuation and continence, as it is for the bladder, but it's easier to have a good self-intermittent catheterization for the bladder than having a good evacuation of the rectum. So also there is the paralysis on the role of the levatoroni, which is completely different in the case of the anorectal function, which doesn't play the same role in the lower urinary tract continence, and that makes maybe the difference. The same for Parkinson's disease, the severity of the bowel dysfunction in Parkinson's disease is often before lower urinary tract dysfunction because the denervation of the anterior plexus appears before, and sometimes defecation is a nightmare for those patients.
Okay, I will introduce the next speaker, which is Charalampos Constantini. We speak about control of genital sexual function, physiology, and physiopathology. Could you share your screen, Charampoulos?
Charalampos is from Greece. Welcome, Greece.
Thank you. Thank you. It's an honor to be part of this very ambitious project, but I'm very convinced that it will be a great one. So our next talk deals with the control of the genitosexual function, the physiology, and the pathophysiology. The term sexual response refers to erection in males and vaginal vasocongestion and lubrication in females. The sexual response is a neurovascular phenomenon that it is under hormonal control. Sexual response is controlled by several centers. The brain centers are located in the hypothalamus and midbrain, but there are also two centers located in the spinal cord. The close collaboration of all centers is essential for a proper sexual response. You can notice the topography of the centers involving the sexual response. Sensory data from the eyes and skin are related to certain areas within the hypothalamus and midbrain where appropriate signals are related to the genitalia as well. The parasympathetic pathways provoke erection or lubrication, while the sympathetic pathways may promote or inhibit sexual response. Several brain regions have been identified as key for sexual response. Sensory impulses gathered at cortical association areas are related by the amygdala to the medial preoptic area of the hypothalamus, which may be the integration point for the central control of the sexual response. There are several neurotransmitters involved in these pathways, including dopamine, oxytocin, serotonin, and norepinephrine. Another area of the hypothalamus, the periventricular nucleus, receives neural input from medial preoptic area and may have an initial action for the expression of the sexual response, potentially through oxytocin descended pathways. The periaqueductal gray matter has neural connection between the medial preoptic area and the brainstem that also may have a similar role. Neurons from the periventricular nucleus are known to project the thoracic and uterosacral nuclei concerned with the erection or lubrication vasoconstriction. There are two centers in the spinal cord related to sexual response. The sympathetic center is responsible for the psychogenic sexual response. It is a pure autonomic sympathetic center located from the 11th or 12th thoracic to the 2nd or 3rd lumbar section of the spinal cord. It is activated by visual and acoustic stimuli, dreams, fantasies, and recalling memories and inputs from previous erogenous experiences. In male, it is also responsible for the emission phase of ejaculation, while in females, it is mediated in the uterine part of the orgasm, so-called the deep cervical uterine orgasm. The activation of the sympathetic center of the sexual response results usually in benign tumescence and not in a hard erection. On the other hand, lubrication and vasocongestion in females are limited, but usually effective as it is further enhanced by time. The parasympathetic center is responsible for the reflexogenic sexual response. The erection or lubrication vasocongestion are the effects of a reflex induced by stimulation of the genitalia and mediated by the parasympathetic and somatic fibers located from the second to fourth sacral section of the spinal cord. In males, it is responsible for the expulsion phase of ejaculation, while in females it is mediated in the clitoral orgasm and pelvic floor contractions. The activation of the parasympathetic sexual response center results in a hard erection with a limited duration in males and efficient lubrication and vasocongestion in females. Teaching patients to provoke this reflex to enhance or maintain their sexual response, it is an important part of sexual rehabilitation. This is a schematic figure of the physiology of sexual response when everything is intact and works properly. When we are exposed to visual or acoustic erogenous stimuli, or we are recalling memories, fantasies, and previous erogenous experiences, the brain centers for the sexual response are activated. If we decide to involve in sexual activity, descending signals to the genitalia through the sympathetic center and directly to the pelvic floor muscles result in the initiation of sexual response. At the same time, when there is a direct stimulation of the genitalia, the reflexogenic parasympathetic center is activated, resulting in penile erection and vaginal lubrication. Neurophysiology of ejaculation as described by François Gugliano in Neurophysiology of Erection and Ejaculation at the Journal of Sexual Medicine in 2011. Central nervous system control of ejaculation is mediated via spinal ejaculation centers, including lumbar spinothalamic cells that constitute the spinal ejaculation generator. The lumbar spinothalamic cells integrate peripheral signals from the genital areas with excitatory and inhibitory control from supraspinal centers, such as the nucleus perigigantocellularis. The spinal ejaculation generator integrates the sensory inputs and outputs necessary to trigger ejaculation by sending coordinated outputs to the anatomic structures that allow ejaculation to occur. The ejaculation reflex consists of emission. It is the generation of semen by the seminal vesicles and prostate gland, and the expulsion, that is the rhythmic muscular contraction involving the bulbocavernosum muscle controlled by the pudendal nerves. In the case of a nervous system malfunction, the sexual response is not expressed adequately. Depending on the extension and the location of the lesion, the sexual function is influenced in different ways and degrees. In the case of multiple sclerosis, which can affect any part of the central nervous system, the influence on sexual response is variable and unpredictable. It is uncertain if the brain centers are activated by visual or acoustic erogenous stimuli or recalling memories, fantasies, and previous erogenic experience. It is also uncertain if they are sending signals of sensation due to direct stimulation of the genitalia reach the brain and have the appropriate input to the sexual response centers. Additionally, it is not certain, due to neural damage, that the descending signals to the genitalia through the sympathetic center and directly to the pelvic floor muscles can result in the initiation of sexual response. At the same time, it is also uncertain if stimulation of the genitalia can activate the reflexogenic parasympathetic center. Under these circumstances, penile erection and vaginal lubrications are variable and usually limited. Pathophysiology of sexual response in the case of a spinal cord lesion above the 10th thoracic level. In this case, the ascending signals of sensation due to direct stimulation of the genitalia cannot reach the brain and have appropriate input to the sexual response center. In the case of a spinal cord lesion above the 10th thoracic level, with above the sympathetic center of sexual response, although visual or acoustic erogenous stimuli or recalling memories, fantasies, and previous erogenous experience may activate the brain centers, the descending signals to the genitalia through the sympathetic centers and directly to the pelvic floor muscles are blocked due to disruption of the neural pathways and cannot result in the initiation of sexual response. At the same time, direct stimulation of the genitalia activates the parasympathetic sexual response center, resulting in reflex penile erection and vaginal lubrication. Pathophysiology of sexual response in the case of a spinal cord lesion below the second lumbar level and above the second sacral level of the spinal cord. Similar to the previous clinical scenario, ascending sensation signals due to direct stimulation of the genitalia cannot reach the brain and have adequate input to the sexual response centers. In the case that the spinal cord lesion is located between the sympathetic and the parasympathetic sexual response center, after activation of the brain centers due to appropriate stimulation, the afferent neural signals may not reach the pelvic floor muscles, but the psychogenic sexual response may occur as the descending signals can bypass the lesion through the sympathetic center. At the same time, direct stimulation of the genitalia activates the parasympathetic sexual response center, resulting in reflex penile erection and vaginal lubrication. Pathophysiology of sexual response in the case of a spinal cord lesion below the second sacral level of the spinal cord. In the same way as in the previous cases, ascending sensation signals due to direct stimulation of the genitalia cannot reach the brain and cause input to sexual response centers. In the case that the spinal cord lesion located below the second sacral level of the spinal cord after activation of brain centers due to ergogenic stimulation, in a similar way to the previous case, the afferent neural signals cannot reach the pelvic floor directly, but the psychogenic sexual response may occur as the descending signals can bypass the lesion through the sympathetic center. On the other hand, direct stimulation of the genitalia cannot activate the parasympathetic sexual response center due to the disruption of the neural pathways at this level. In this case, the reflex arc is not working and there is no reflexogenic sexual response. Pathophysiology of sexual response in the case of a peripheral neural lesion. In the case of a peripheral lesion, it is uncertain if the ascending sensation signals due to direct stimulation of the genitalia can reach the brain and result in an input to the sexual centers. On the other hand, after activation of brain centers due to visual or acoustic erogenous stimuli or recalling memories, fantasies, and previous erogenous experience, descending signals to the genitalia through the sympathetic center and directly to the pelvic floor muscles are blocked due to the disruption of neural pathways at the peripheral level and cannot result in initiation of sexual response. Additionally, the parasympathetic sexual response center cannot be activated by direct stimulation of the genitalia for the same reason, the peripheral neural lesion. In this case, erection and lubrication cannot take place. Summary and conclusions. For a sufficient sexual response, the integrity of all the involved neural centers and pathways is required. Depending on the location of the nervous system lesion and its impact on the neural signals, the sexual response is affected in different ways and degrees. Additionally, be aware that the vascular and the anatomical integrity of the organs of the genital system is required as well for a proper sexual response. Thank you. I will stop sharing now.
Thank you. There is no question on the screen, but I have a question to you. Can you explain people who are hearing at your talk, how do you explain presence of orgasms in a complete spinal cord injury woman at the C6 level?
Actually, it is described that maybe more than half of women can experience orgasm. I think it's more complicated because maybe during with the reflex arc from parasympathetic and sympathetics can work, but also we don't know how can the supraspinal centers can influence the centers of the orgasm in the spinal cord. So it is more complicated, and I think we cannot have an explanation only seeing at these pathways. I think for the organs, they are related to many other pathways and circuits that they are working in the brain that the woman can experience the orgasmic sensation. And sometimes a phenomenon similar to dysreflexia, it is experienced as orgasmic phenomenon for some tetraplegic women. I don't know if Pierre has something to add, or you, Brigitte.
Sipsky, the work from the group of Sipsky was thinking perhaps you have some afferents through the vagus who can produce orgasmus in a complete cervical spinal cord injury woman. I wanted to ask you if you join this theory or if you have another one.
I think that I'm not sure if the theory is very true, but through the vagus nerve, there is a sympathetic connection between some brain centers and the genitalia. So maybe they have, maybe also it has a role for that.
Okay.
We have a question, but it's more on pudendal nerve, and I think it will be better if we ask the question after the talk from Jersey. I have the question from Jane, but I think it's better to ask the question on pudendal neuropathy, pudendal neuralgia after the talk from Jersey.
Okay.
I have just one question for Charalampos. You described very well the pathophysiology, but there is still, for me, a mystery. You know, those patients with spinal cord injury, usually conus medullaris lesion, who do experience premature ejaculation after the injury. And it's always, for me, difficult to try to find the real pathophysiology behind it. There is some patient with that, and it's not as infrequent as we imagine in this type of lesion. Do you have an explanation for that?
I think that regarding the theory of the spinal generator of ejaculation in the sacral area, we are not. It is the only theory that we have from François Giuliano, but it is not very clear because sometimes we see this phenomenon as you described that cannot be covered by these centers.
No.
So I think there are more connections for this for the ejaculation and the orgasms than we still know, and I think that there is a lot of work to do to explore more these pathways.
Okay, thank you, Charalampos.
Thank you.
Okay, then we move to Jerzy. Jerzy Gajewski from Canada. Jerzy, we speak on the new terminology of symptom and dysfunction in clinical neurourology. Jerzy, can you share your screen? Yes.
Yes, it's now share, I think.
Yes.
Yes. Yeah. So good morning, good afternoon, good evening to everybody from whenever or whatever country you're watching this symposium. Welcome in these extraordinary times. I will be talking today about terminology. Could be a rather boring topic, but it's very, very important that when we interact with the patients, with individuals, we look at the symptoms and observe the different situation, we know how to call it and how do we relate it to the patient, how do we relate it to other health providers, and how do we do research knowing what we are talking about. So that's why terminology is very important. So let's start with what is neurogenic lower urinary tract dysfunction. It is defined as lower urinary tract dysfunction secondary to confirmed clinical relevant neurological disorder. So, to be diagnosed, you have to have presence of neurological pathology. And the previous, we call it neurogenic bladder dysfunction, but this definition were misleading because they only talk about bladder, and we know urethra and urethral sphincter and other part of the lower urinary tract take also part in dysfunction. And a single term may indicate rather more broad spectrum of dysfunction and reductive and probably confounding. So let's talk about clinical condition or dysfunction. So condition are clinical manifestation of symptoms and signs. They may be characterized by specific urodynamic findings or evidence defined by the presence of observation associated with characteristic symptoms or signs, or non-urodynamic evidence of relevant pathological processes. So neural lesions are described according to the time of onset, risk of neurological progression, completeness, and neurological level. This was already mentioned previously by Professor Hamid about the classification of neurological lesion, but I briefly repeat it. We have suprapontine lesion, which is a lesion in above pons and forebrain or midbrain. The reflexes are voiding reflexes are coordinated. That means the trousseau contracts, sphincter relaxes. However, there is no inhibition or no control of this reflex. There is a suprasacral spinal cord pontine lesion, which is usually show as the trousseau overactivity and the trousseau sphincter dysenergia, because we lost the pontine regulation center or coordination center. So bladder contract, sphincter may also contract and may very often resulting in high post-void residual and high pressure bladder. Then we have the sacral spinal cord lesion. In the sacral spinal cord, usually the trousseau is acontractile. It may be also decreased in the bladder compliance, and there is impaired sphincter activity. It may be associated with stress incontinence. And then it's infrasacral, which is called equina peripheral nerve lesion, and that's also cause acontractile the trousseau, but also quite significantly may affect sphincter. But if it's not complete and in diabetic neuropathy, the trousseau of activity can also be seen in this lesion. What about spinal shock? It's a temporary condition following acute neurological insult or spinal cord injury. It's characterized by loss of sensory, motor, and reflex activity below the level of injury, resulting in a complete painless urinary retention. Another definition, autonomic dysreflexia. It usually is a syndrome resulting from injury above T6, and it's in the area of distribution of autonomic sympathetic nucleus, and it's potentially medical emergency characterized by hypertension, bradycardia, severe headache, flushing above, and pallor below the lesion, and sometimes convulsion. So it is medical emergency. There's also sometimes we talk about asymptomatic autonomic dysreflexia, which is only characterized by increased blood pressure without any other symptoms, and that can happen during routine urodynamic investigation or bowel program. And there's therefore, it is important before such a test is done to make sure that we are prepared for this event. What about the neurogenic overactive bladder? It's the same like overactive bladder, which is characterized by urgency with or without incontinence, usually with increased daytime frequency in nocturia, but in this case, in the setting of clinical neurological disease. And one important is at least partially preserved sensation. If you don't have sensation, you cannot say it's overactive bladder because you don't have urgency. So this is a neurogenic overactive bladder. And obviously, as in general, overactive bladder can only be considered if there is no proven infection or other obvious non-neurological pathology in this case. So other conditions which are specific for neurogenic dysfunction is voiding dysregulation. This is voiding or urination in generally regarded in places socially inappropriate. So that means patient knows the bladder is full, patient wants to pee, but it doesn't care. He just pee when it's dressed or in the middle of the street. He doesn't have appreciation of the surrounding, but he's aware of bladder sensation and aware of bladder emptying. On the other hand, involuntary voiding is the both in symptoms and condition. When the bladder is emptying, when patient is awake, but individual doesn't know about it, doesn't know that the bladder is full, he doesn't want to pee because he's not aware of that. However, it is happening. If that happens when adult is asleep, it's called acquired enuresis. And urinary retention is like in any general dysfunction. You may have complete, incomplete, and the incomplete is only when the voided volume is smaller than post-void residual, and of which post-void residual is defined whatever is left in the bladder after voiding. We don't have actually the numbers for what's normal and what is abnormal for post-residual. Bladder sensation is very important for the patient with neurogenic conditions. Normal, obviously it's normal, and patients aware of bladder feeling and strong desire to void. It's increased when individual feels an early and persistent desire to void, or decrease or reduce. The individual is aware of bladder feeling, but does not feel a defined desire to void at an appropriate time, or absent when there is absolutely no sensation from the bladder or the tract to void. There are some non-specific bladder awareness. That means patient may perceive blood, abdominal fullness, vegetative symptoms, urethral sensation, or spasticity as a bladder feeling awareness or sign of bladder fullness. But there's also abnormal sensation, which is coming from the bladder or urethra or pelvis, described as a tingling, burning, electrical shock. And this has to happen in the clinical, in the setting of the clinical relevant neurological disorder. And obviously abnormal sensation cannot be seen in a complete spinal cord lesion, only in incomplete one. And bladder pain, obviously it's a pain in the suprapubic or retropubic, usually with increase in bladder feeling, and may persist after voiding. So the symptoms of neurogenic lower urinary tract symptoms are, again, just to emphasize, it's like with dysfunction, the symptoms are also classified as neurogenic in the presence of relevant neurological pathology only. And obviously symptoms are subjective indication of disease and changes in condition, and may either be volunteered by patients or described during patient interview. And in general, lots are not enough to make a definite diagnosis. They may suggest, but especially in patients with neurological disease, lots can indicate pathology other than neurogenic and like urinary infection. So it is very important to be very careful how you evaluate the patient. And in general, the symptoms can be storage, voiding, and post-mituration. So storage symptoms are experienced during storage of the bladder and include increased daytime frequency. I just want to emphasize that it's not a number. It's just what the patient feels that it's going to more frequently. Obviously, when you do research, you put the numbers patient voids during the day, but patient may say, okay, I'm voiding 6 times a day, but this is for me increased daytime frequency, and that it is what its terminology says. And again, nocturia, it's a number of time urine is passed during, and here it is emphasis, main sleep period. What does it mean? If somebody works at night and sleeps the day, this will be during the day, not during the night, a number of times urinate. And patient has to be woken to pass the urine first time and followed by sleep or intention to sleep. So when you wake up at 7 in the morning and you don't want to go to sleep again, that doesn't count for nocturia. And the sign of nocturia is number of time individual pass urine during the main sleep period. Urgency is the same like general. It's a sudden compelling desire to pass urine, which is difficult to defer. And urine incontinence is the individual report any leakage of the urine. In neurogenic dysfunction, it is important that some symptoms cannot be defined properly when there is a reduced or absent of motor or sensory function. What about urinary continence? We know about stress urinary continence. It's a leakage of urine on effort and exertion. Urgency urinary incontinence, complaint of leakage accompanied by immediate and proceed by urgency. Mix obviously is between stress and urgency. And there's continuous incontinence, which is involuntary loss of urine all the time, but it's not related to any specific symptoms or situation. We have a specific for neurogenic condition terminology. Impaired cognition urinary incontinence. It's urinary incontinence that happen that individual reports to have occurred without being aware of it. So patient is not aware because of probably suprapontine lesion that the bladder is contracting and patient is continent. There is also another one, impaired mobility urinary incontinence. The patient is aware that he has to go and pee, but it's because of mobility problems, he is unable to reach the toilet on time. And there are different situation type urinary incontinence like giggle incontinence or incontinence associated with seizures. And sexual activity incontinence, it's incontinence associated or during sexual activity. And this is important to know, it's sexual activity, not sexual intercourse. Enuresis, there's a complaint of incontinence during period of sleep. It's occurred during, again, main periods of sleep, and it could be qualified by adding nocturnal. The patient must be asleep when enuresis happens, and patient is usually unaware of it. You can primary enuresis when it's presented from lifelong. Secondary is in children when they were dry for 6 months and then become wet again. or acquired aneurysms that's happened in adults. So it has to emphasize aneurysms is considered different from urgency urinary incontinence, because urgency indicates the patient is aware of bladder voiding, and usually aneurysms is not. What about voiding symptoms? The slow stream, splitting or spraying, the self-explanatory intermittent stream, hesitancy, and straining to void and terminal dribbling. These are obviously very self-explanatory symptoms. There are post-micturition symptoms. It's a feeling of incomplete emptying experienced by the individual after passing urine. And that not necessarily mean that there is some residual urine in the bladder, but it may be that the bladder is such a hypersensitive that it feels like there's some urine left. And there's post-micturition dribble, which happened after finishing your voiding and you still some dribble after you leave the toilet. So in conclusion, standardized terminology is a very important aspect of research and communication in neurogenic lower urinary tract dysfunction. ICS continues to have a key role in standardizing terminology related to this urinary tract and pelvic organ dysfunction. Thank you very much.
Thank you, Jerzy. I think it's really important talk because we need a standardization to exchange report and publication. We have a question for all. I think it's a good question now for terminology, because but it might be a question for all of us, which is from Jen. We ask, we have heard a little here about the pudendal nerve. Some our ICS BPS patients are told they have pudendal neuropathy or pudendal neuralgia. What is the difference between the two, and what is the effect on the bladder? It's a question for all the speakers. You want to repeat the question?
No. I think here there is definition for pudendal neuralgia, and there is criteria already published for that. This is the Nantes criteria, which were based on international consultation on pelvic pain. The Nantes criteria have 4 criteria: a pain which is usually a sensation of burning, no pain during night, increasing in sitting, and the last criteria is that there is no usually hypoesthesia in the territory of the pudendal nerve. So this is the 4 criteria, and the question here is if there is condition where you can have a pudendal neuralgia as well as interstitial cystitis and bladder pain syndrome. And yes, it's true that in the pain area, there is a lot of overlap between the different pain that you may have. You may have irritable bowel syndrome and bladder pain and pudendal neuralgia. The pathophysiology of each is different, but having a chronic pain is a strong risk factor to have pain in another territory or in other area of the body. So there is overlap in terms of epidemiology, but criteria for the diagnostic are completely different.
Yes, we have another question from Julian. who ask if DST only happened during voiding. Perhaps a question for you, Jerzy, or can we call dyssynergia sometime during storage in some patient in spinal cord injury?
Yes, actually, it's not only during voiding, because when you have the trusor contraction and at the same time the trusor sphincter dyssynergia, it's so strong that the patient cannot actually void, but it is still the trusor sphincter dyssynergia. And proper detrusor sphincter dyssynergia is then when there's increase in pressure of the detrusor coexistence with increase of sphincter activity in the same time. And it's so if you have that, yes, you can call it in the storage too.
Any question from the other speakers? No. So we will continue with you, Jerzy, with the clinical evaluation in NLOTD.
Okay, hopefully, is it my share or not? I think it's okay now. Can you share it?
Yes.
Yes.
Jerzy, can you speak in the microphone? Sometimes it's difficult to hear you.
Okay, is it any better now?
Yeah.
So the next topic is about symptoms and clinical evaluation in clinical neurourology. Obviously, it's a large topic, so I will be just briefly highlight the most important aspects. In neurogenic lower urinary tract dysfunction, clinical careful evaluation, history, symptoms, importance of identifying frequent and critical complications are one of the most important aspects of the management of patients with neurogenic lower urinary tract infection. I have to really stress that this is very, very important, very, very important in managing of this patient. So in general consideration, you look at the neurological diagnosis, obviously acquired, congenital, and so on, year of neurological injury or disease inception, coexisting non-neurological problems like enlargement of the prostate, stress incontinence, previous non-neurological or neurological surgery like diversion, cystoplasty, sphincter stents. You have to make sure that you know other medical conditions, cognitive function, metabolic disorders, bladder renal disease, and UTI. You definitely have to exclude this situation. Obviously, you're looking at gynecological pregnancy history, allergy, medication, and so on, so on. And very important, what are the medical treatment right now taken by the patients? Anticholinergic, pain medication, antibiotic, alpha receptor, they're all very important to look for. Quality of life and support system and caregiver, because that will probably give you some idea what kind of treatment or management of the neurogenic condition you can offer the patient. So history, you have to ask for present and previous voiding patterns, storage, voiding symptoms, including types of incontinence. Some symptoms cannot be defined in neurogenic condition because of reduced motor and sensory function. Sensation is very important because in a lot of patients with neurogenic condition, this sensation is affected. The sensation of the suprapubic fullness remain present with preservation of afferent from gut peritoneum if cord lesions are below the 10th thoracic segment. Cord lesion at 6th thoracic segment, sensation of fullness is less localized and experience a vague abdominal distension. Abnormal sensation, we talk about it, about tingling, burning, electrical shock, non-specific, when it gives you perception of bladder filling by abdominal fullness and other spasticity, or non-bladder awareness. And sometimes you have to ask supplementary questions to ask if sensation was the same as before, as sensation associated with other situation, and if there's a difference in voiding. You have to be aware of so-called alarm system that gives you some idea how urgent or acute is the situation, like fever, hematuria, pain, a problem with its catheterization, clinical infection, and sign of autonomic dysreflexia. And as we talked about before, autonomic dysreflexia can occur only with a complete thoracic lesion above T6, but sometimes it's also present with incomplete lesion. And other pathology like ureteral ectopy, fistula, bladder neck erosion, scarred urethra, because of the catheters is also important to define. Some incontinence, we already talked about continuous incontinence when there is continuous involuntary loss of urine. However, you have to exclude, like here, fistula or other anatomical pathology. Impaired cognition, we talk about it, it's impaired when a patient is unaware that there is a bladder fullness and voiding. Impaired mobility, when it's unable to reach toilet on time. Sexual activity and other situation types of urinary incontinence, we already spoke about it. Diary, bladder diary and questionnaire. We have a lot of questionnaire for regular lots, but for neurogenic lots, its reliability of general symptom questionnaire is low. We have, however, few validated questionnaire for neurogenic lots, and that's actually mostly from Canada. It's 24 items, neurogenic bladder symptom score, and shorter form, 8 items. And Qualin questionnaire. At the bottom, you can actually access this questionnaire through the website. Bladder diary are very, very important in a patient with neurogenic clots. They give you number times of micturition, number of catheterization is important, cessation and each voiding, degree of urgency, voided volume, episodes of incontinence, pad usage, and fluid intake. There is no like consensus or guidelines how many numbers of days you should do it, but ICS recommend 3 days. And also bladder diary are very helpful in assessment of treatment outcomes. Other symptoms, look at the bowel history, symptoms, anorectal symptoms, previous defecation pattern, fecal incontinence, rectal sensation, mode and type of defecation, and bowel management, what is present. Sexual history, you look at genital and sexual dysfunction present now, previous sexual function, sensation, erection and arousal, orgasm and ejaculation is important to evaluate. Then mode of type of voiding. Balanced bladder emptying is emptying with physiological detrusor pressure, low residual, as perceived by investigation, and it should be defined in the report. So balanced bladder emptying is almost like a normal bladder emptying. However, if there is a decreased sensation, you still can have a balanced bladder emptying, but without proper sensation. Initiated reflex bladder emptying is artificial illicit LUT reflex, and usually comprised of various exogenous stimuli performed by patient on therapist, resulting in the complete or incomplete bladder emptying. Voiding dysregulation, we already said that it's a voiding in a situation generally regarded as socially inappropriate, like fully dressed or in a public setting. And involuntary voiding, it's sporadic voiding when patient is unaware of or have intention to void. Bladder history, history of bladder management is very important. We need to know time voiding, habit retaining, prompt voiding, bladder reflex triggering, what kind of trigger actually cause bladder to empty, like suprapubic tapping, thigh scratching, anal rectal manipulation. Bladder explanation, it's either Valsalva by abdominal straining or by Crede technique by pushing on the suprapubic area. And then we have to know if patient has a condom drainage or catheterization. So catheterization is technique of bladder emptying employed by catheter to drain bladder or urinary reservoir. So it is important to record type of catheter, size, and technique. We have indwelling catheters, which remain in the bladder constantly. Then there is intermittent catheterization. It's defined as drainage of the bladder or urinary reservoir with subsequent removal of the catheter on regular intervals. We can have a clean, but just ordinary hand and general washing. You can have a aseptic, which implies genital aseptic preparation, and sterile single-use catheter. Sterile IC is complete sterile setting, usually in the OR, and so-called non-touch technique. There's recently developed by industry already pre-lubricated catheter, ready to use, usually with hydrophilic cover. Your patient just or individual has to pull in 8 of the special packages and directly, non-touching the catheter, you can slide into the bladder. Important is focal neurourological history adapted to neurological dysfunction. For example, in spinal cord injury, we have to know time of injury, level, completeness, ASIA levels, frequency, autonomic dysreflexia, level of spasticity. We have to know dexterity, mobility, and transfers for this patient. Multiple sclerosis, we need to know if it's a primary, secondary, or relapsing. Mobility level, expanded disability status scale. Spinal bifida, it's ambulatory, or it's a VP shunt. About latex allergy, which are very often. Pre-reconstructive surgery. Parkinson's disease, usually it's a patient had overactive bladder, but also has BPH because of the age of this patient. They have, we have to look at the function, mobility, and dexterity. Multiple system atrophy, which is a little bit more serious and most often associated with high post-polio residual. Vascular dementia, Alzheimer, Parkinson group dementia, and so on. We look at the cognitive function, incontinence, bladder perception, level of the disability, and speed of progression and support of caregiver. Cardiovascular accidents, we can use a manometric diapers, activity of daily living, instrumental activity of daily living, and we have to be aware of other medical conditions like atrial fibrillation, size and of the lesion. Diabetes, presence of diabetic neuropathy, so we're looking at bladder sensation, renal vascular disease, so we're looking at renal function, UTIs are very often, and obviously we have to look at overactive bladder versus underactive bladder. So in conclusion, the majority of patients with neurogenic lower urinary tract dysfunction will require at some point a neurourological evaluation. The patients with newly acquired spinal cord injury should occur within 3 to 6 months of the spinal cord injury. Other patients with other complications should be considered for evaluation as possible as after spinal cord injury. Many patients with MS do not require or need urological management during the initial years of diagnosis, but that at some point when progression MS, risk of bladder dysfunction increases as mobility and function status decreases. And that's when this assessment is more relevant. And children with spina bifida should be initially evaluated by pediatric specialists, but very important that the transition to adulthood should be done with the adult specialist, and as soon as possible, it is practical to transition them. And here is the, you can use reference and to this neurological evaluation. Thank you very much.
Thank you, Jerzy. There is no question on the screen. I have perhaps a question. Do you think that the urological examination, I mean clinical neurourological examination, will help to choose what kind of specific examination you will emphasize for your patient? I mean, probably you will emphasize urodynamic in any spinal cord injury patient and choose another way for dementia, or do you think that from the clinical evaluation it will help to choose what examination you will prescribe to your patient?
Well, I was talking only about clinical evaluation.
Yeah, I know.
So, but urodynamics are very important. We all.
I mean, my question was: do you think that the neurourological examination will help you to choose what kind of invasive examination you will choose for your patient?
Oh, definitely, because then you know which direction. You have spinal cord injury, suprasacral lesion, you know patient probably have the trusor overactivity with DSD, so you go for urodynamics. If you have a suprapontine lesion and patient void without residual, you just do uroflow. So it's obviously help you very much. So how do you proceed with other evaluation? Like when do you do renal ultrasound? You do probably in most of the cases, but when do you repeat? When it's normal voiding, or you don't need to repeat it, only if there are some suggestion of stones, infection, and so on. So definitely evaluation, clinical evaluation, give you some idea which direction to go with the further test.
Yeah. But also in some cases you can, for example, have a multiple sclerosis male patient with bladder outlet obstruction. Perhaps you will not perform urodynamic if you have no idea of bladder outlet obstruction, but if you have a combined situation, perhaps you will push for urodynamic examination in this case. Just an example, I choose this one, but it might be another one.
Well, sure, but if patient has no symptoms, then you probably don't want to do any more tests. But if the patient has infection, then you do uroflow and post-void residual, and they give you some idea what to do next. I don't jump in MS patient directly for full urodynamics, just because not everybody needs it. But you really need careful examination, clinical and ultrasound. Yeah.
Yeah. Any question from the co-speaker? There is no question on the screen?
No.
No. So in this case, for my part, I will thank you, all of you, to take your time on a Saturday afternoon to participate to this ICS course, and I will give the last word to my co-chairman, Pierre Denis from Paris.
Thank you everyone one more time for your wonderful lectures and the good time we spent together and with the audience. I hope that we fit with the goal for the basics. For the first content, please don't forget that there is other ones. And I would like to thank the Neurourology Promotion Committee, the ICS, for all the support and all the colleagues who did the job to make this happen. And thank you, Rizwan, for your support as the chief of the Neurourology Promotion Committee. The last word is for you, Rizwan. Thank you one more time to all of you. And hope to see you soon in Rio.
Yes, thank you very much, Pierre and Bridget, for sharing. I think thank you for the audience for watching this live session. I just want to say that we hope that the people who have attended gained a lot. And if they want, they can join us live in the ICS lounge. And if you wish to discuss the topic further with the speakers and other people watching, that can happen today. The link is just above this section. And the last thing I want to say is that I think COVID has changed our lives upside down. But I think ICS has been one of the organizations from the very start, has been very active in holding webinars and teachings and doing online training. So please visit the ICS live page to find out about the upcoming live events. So thank you very much and stay safe. And thank you to everybody and good evening.